Alrighty, so before we get started with the lecture, exam 2 results were posted. The high was a 94, and there were 5 traditional A's, meaning 5 people got 90 and above. And then the mean or average was 60, and the median was 58. So half the class did better than 58, half did worse than 58. And there were some students that I noticed who improved from exam 1 by 20 points or more, which was fantastic. So whatever you did to do those changes, you did an awesome job. Unfortunately, there were also a number of students that did 20 points or worse than their first exam. So do what you did before, or whatever you tried this time or did different didn't work. And yes, the exam was a little harder than exam 1 because you were taking information even that you learned in exam 1 and you were applying it to exam 2 material. So some was a little review, but it was adding on to that story, if you will. And you guys have noticed that even as we go on into exam 3 material, we're building on stuff that you had to have learned in 1, and then exam 2 material, and then moving on to now 3. Let's see. So, and who knows what some of the other reasons were. Either somebody tried something different and it didn't work for them. Maybe life happened. Kids got sick, you got sick, didn't get to study like you had anticipated. Who knows, right? A lot of different things. Other exams may have been going on, and this one maybe went by the wayside a little bit. Who knows, right? So for those that felt like they really studied hard but scored the same or worse, please come and talk to me so I can help you. I may say the same thing that I'm telling everybody else, but sometimes one-on-one, it makes a difference. Or you can tell me what you had tried to do when you were studying, and I can help modify that and give you some other pointers on what might work better, okay? So I'm not mean, I don't bite, and don't be embarrassed to come and talk to me, okay? Sometimes it'll make a world of difference when you come and you talk to your instructor, all right? One of my favorite classes in undergrad was organic chemistry, because my partner, who I thought was like genius smart, she could read anything and score like 100% on an exam. And when I was studying with her and she's like, I don't understand this. Maybe we should talk to the teacher. And I thought, oh, I'm screwed. If she doesn't know it, I'm in big trouble because I definitely didn't get it. And we went in and we talked to the teacher, and I was too shy or nervous to try to talk to the teacher. I didn't want the teacher to think I was an idiot or didn't know. But that's the point. You got to come and ask for help or we can't help you, right? And I have to tell you, after I talked to that instructor, it was my favorite class. My score improved dramatically because it finally made something click. The questions that we asked, it was like that basic information that helped you understand, and you could apply it now to, as you build on every course, you build information on that. So makes a world of difference. Don't hesitate. Come talk to me after class, in my office, whenever, okay? Email me, whatever it is, but usually face-to-face is a little easier. You should try small group studying, okay? 3-4 people maybe, not probably more than that. You could try, what worked best for me was me holding my notes in front of me and me quizzing my partners. And if they didn't know it, I was looking at my notes and telling them what the answer was. It was a form of studying for me. For my partners, it worked well to be quizzed first. If they had quizzed me first, I was like, I don't know. I felt like an idiot. But it worked well that I could quiz them. Then if they turned around and quizzed me, I knew it. Okay, so if you were like the teacher, and it makes a difference, not just talking to the mirror or the cat or your children or your spouse or significant other that has no clue whether what you were telling them is right or wrong, okay, and they can't ask you follow-up questions like a study partner or another fellow student can do. So that's why I say it really does help to talk to somebody else. If you're getting tutoring, if you didn't get tutoring, go try tutoring. They have an additional tutor there now. And some students may have dropped the course and there may be an opening, so go try that. But if you do tutoring or in small groups and somebody explains something to you because you didn't quite get it, you should say, hold on, let me see if I got that right. And you reiterate it back to them. Because when you verbalize it, that's when you or the other people will hear where you're missing some part of the story and they can help correct you then, okay? Also, let's see, chunk up your studying into segments. So we were trying to get some of you guys to do that during the last lecture. There were things where you could break things up in a chart for the different categories. Some of you may have tried it. It may have worked great. I don't know. Some of you may have tried it and felt like it was a waste of time. I don't know. you have to come talk to me and let me know, or post in the blog and say, I tried that stupid chart thing and that was ridiculous, you know, or maybe you didn't utilize the chart right because you didn't know how to categorize it, something. But let, you know, do not hesitate. If you did well on the exam, please post on there what you did after those exam results. Post on there, what did you do that seemed to work for you? May not work for somebody else, but it might be that little thing that helps somebody else go, maybe I should try that. Sherry Zayo always mentions rewriting the notes. That wasn't an effective way for me, but for some people that might be very effective. So it just depends, but you got to find what's going to work for you and make that change now as you're studying now. Don't wait until exam 3 or say, well, maybe next time. If you're doing the exact same thing and still not getting the grade you wanted, you have to change what you're doing. Okay, it doesn't mean that you did something wrong. It just means you weren't studying effectively for you. Okay, and what works for one person may not be the right one for you, and that's okay. As you guys have seen, there's a lot of memorization with A&P. There's always going to be a lot of memorization for A&P. But the other part that makes these questions difficult on the exam is that they are not just straight memorization, but also they are thinking questions. If this happens, then that happens. If we taught you it this way, this is superior to this, could it also be medial or lateral to that? Okay, so you have to think not just what you're doing, and you may not have studied it that way, but if you understood the material, you should be able to draw upon your knowledge to get that side information. Does that make sense? Hopefully. Okay. Let's see. Also, prioritizing, you know, whether it's other classes or this one, but you should not be spending more than 4 hours, no more than 4 hours. Please don't spend 4 hours a week on your lab information. Your lab is supplemental to what you're learning in here. So most of what I'm talking about on the bones right now, hopefully you guys all have under your belt. I'm just adding to that information a little bit because you already studied bones, you already had your bone eval. But now you guys are learning about muscles, and hopefully you are starting to make the connection of those sites and little things that you had to identify, those landmarks on the bones, are where these muscles now attach, or those sites were named because of this muscle that attaches there. So I'm hoping that you are getting a review of bones in here with me right now as you're learning muscles in lab. Does that make sense too? I hope. Okay, so review isn't bad, but lab is only worth about 1/3 of your grade. So if you are spending more on your lab stuff, that does not make sense when the majority of your grade comes from lecture exams. You should be spending more time reviewing and understanding your lecture notes than the amount of time you may have been spending in lab. So make sure that you flip that around if you were doing the opposite, okay? So lab is good. Lab should help you utilize the hands-on part of learning, supplementing what you learn in here. Sometimes you're going to learn it there before you get to learn it in here, but it should not be more than what you are doing in this part of the class, okay? I am not saying let lab go by the wayside, all right? Because in lab you have like 5-point evals, quizzes, notebook checks. Think of them like your cushion points, right? So if you are doing well in there and just staying on top of things, and you're getting 3s or above on something that's worth 5 points, you're doing good. It's not going to drag your grade down. But if you're getting 1s and 2s on stuff, it will start to pull your grade down on top of if you're not doing well in here. Okay? So aim for that 3 to 5 when you're doing your evals and quizzes and things like that. If it's a 10-point eval, aim for 7-ish, you know, but don't let lab overtake your life. But it does help. It fills in the little gaps for you, point-wise. All right. Midterm grades will be calculated soon, and I will end up making a post on the A&P website once they are calculated. The way it works is your grade ends up being a little lab heavy on the midterm grade because you've only had 2 exams in lecture, and like what we do at the end of the semester, we drop the lowest score. So your highest score is the only one that will be counted for the midterm grade. It's not dropping the lower one completely, it's just dropping it for that calculation. When you have your grades at the end, then out of your 5 exams, plus exam 6, which is the final, out of those 6 exams, one of those scores, whichever one is your lowest, is the one that's dropped. Okay? So for now, for the midterm grade, only the top out of the 2 exam scores are counted towards it, and then I will let you know when I make that posting what of your lab grades are ended up in that midterm calculation. So I'll let you know how many notebook checks or quizzes or evals end up making that up. So you'll know exactly what made up that grade, okay? So I think midterm grades are due by the end of the first week of March. And so probably sometime the end of this week or early next week is when we'll have the midterm grades calculated for you. And let's see, we started exam 3 material before the exam, which was the skeleton chapter 8, and we got to the coccyx, and we are going to finish up the axial skeleton and start working on the appendicular skeleton and then articulations or joints. So let's see, did I write in the notes afterwards after we talked last time? Okay, so I put in there for the sacrum, 5 fused into 1, has a superior articular process. We said fusion completes between around age 20 to 30 years of age. And remember, I was saying that you kind of have like remnant discs in between there, but they're gone. So once in a blue moon, you'll have a patient that comes in and you see on an x-ray an actual disc space. And you're like, huh, it didn't fully fuse there. Okay. It articulates with L5. So it has a joint with the body of L5 above it. Okay. And then it has 2 auricular surfaces on the posterior ala. So those are the wings of it. So you're looking at the anterior side of the sacrum, and I circled the 2 ala. So it's the posterior side is where you would see the actual articulation site, the auricular surface, sorry. So that's where it articulates with the ilium of the pelvis. What is the name of the bone that the ilium is part of? The os coxa, which we'll talk about in a minute, because os coxa bone is, or hip bone, is part of the appendicular skeleton. Sacrum is part of the axial skeleton, right? So you want to make sure, you guys should already know that from lab, but I just wanted to point that out. And this ends up creating the SI joint that we talked about, sacroiliac joint. It's nice when your joints are named for the bones that they are a part of. So sacral, S for sacral, I for iliac, or the ilium, so sacroiliac joint. So when somebody says my SI hurts, that's what they're referring to. But as I mentioned before, sometimes when people say something hurts, they're using a layman's terminology, and it's always good to say, point exactly to where it hurts. Because I cannot tell you how easy it is to misunderstand what your patient says to you and what you assume because of the language that they use. They're not using the same language as you are. You are using the medical language, the anatomical language. That is what all doctors, nurses, PAs, PTs, everybody is using that language. But sometimes people that have that additional knowledge forget that their patient doesn't have that knowledge, right? So always say, could you point exactly to where it hurts, or where does it hurt the most? Stick your finger on it and show me. On yourself, not on me, you know, because you don't want them poking you in weird places. All right, and then we said the coccyx is 3 to 5 fused bones into one by age 25 called the tailbone. So this is your coccyx. It has a movable joint between the sacrum and the coccyx, and people can have that shift or move that can make other things uncomfortable, and usually it happens from slipping and falling type injuries. So. Let's see, moving on to the thoracic cage. So we're still talking about, I'll leave this so you guys can read that. So we're still talking about the axial skeleton. So thoracic vertebra, ribs, and sternum make up the thoracic cage. So the thoracic cage is a combination of bones, not one bone by itself. And so if we take a look, the thoracic vertebrae are on the posterior side of the body. The ribs are kind of the lateral portion, not that they don't come from posterior and come up anteriorly, but then the sternum is your anterior connection of the thoracic cage, right? So sternum, another name for that is breastbone, and it's along the anterior midline of the thorax. The sternal angle is a landmark that people will use. And this is where the second rib attaches. So it's where the manubrium joins the sternal body. So you had the, I don't know if we have a picture. So you have here the manubrium is this part of the sternum. Here is the sternal body. And then of course you have your little xiphoid process there. So if you go between, this is the sternal angle here between the manubrium and the sternal body. And that's where rib 2 is attaching. So this is your second rib attaches at the sternal angle. Okay. And let's see, so manubrium plus sternum is your sternal angle. And then if we look at ribs, so you guys notice there weren't a whole lot of things to name on a rib, right, for your bone eval? Right, so you had to either get all of it right to get your 5 points on that bone if you had that during your eval. And if you missed just one, you missed a lot, right? But if, let's say, you had the femur or the os coxa bone or the sphenoid bone, there were a lot to name on there. So you had a little wiggle room. If you miss a couple things, you could still have gotten 5 out of 5. So it was kind of nice when you had the bone that had lots to name versus sometimes a little bone. But on the ribs, so there are 12 pairs. Anybody think we have more in men or women? Okay, we have the same. We have 12. 12 on men, 12 pairs, and 12 on women, 12 pairs, okay? So it's not that there aren't stories that we learn about and we use to understand things, and it doesn't mean something is false or untrue or anything else. And there are lots of ways to interpret stuff, but for anatomy and physiology, there are 12 pairs of ribs. Occasionally, somebody can have a lumbar rib or a cervical rib. We are not going to talk about that in here so much. I'm just putting it out there if you've heard that terminology before. So a lumbar rib would mean that somebody actually has an elongated transverse process or an actual additional bone, like a movable segment, kind of like another free floating rib, like at L1 or something. Or a cervical rib, again, the transverse process could be elongated, so they'll do certain measurements and say, oh, that's a cervical rib. Or they may have a movable joint and actually have a segment of a bone sticking off. Sometimes somebody would never know they have that additional bone, just like you guys noticed on the skeletons. Some had 6 lumbars. They might have been slightly longer in the torso. Maybe you never would have noticed that on somebody, right? These are things a lot of times people don't know. But sometimes if you have a cervical rib, you might have more other issues like nummy tingly in the hand or things that could be putting pressure on the brachial plexus, nerves and vessels that come out that way. But you don't need to know that for us. Just putting it out there. Interesting factoids that nobody needs to know here. So on your rib that we had in the picture here, you had a shaft, an angle, a neck, a tubercle, and that was kind of about it to name, right? As far as with the ribs, they articulate with the body and transverse process of the vertebra. So we already talked about the vertebra and where a rib would attach. And you guys may have realized there was a lot more to name on the vertebra than maybe you did on your lab eval, right? For the bone eval, if you ended up with a vertebra. So remember, name as many things as you possibly can. Identify as many things as you possibly can in lab. Now, when we look at our 12 ribs, the true ribs are called the vertebrosternal ribs, and those are ribs 1 through 7. So what they mean by that is you have the vertebra attaches at the back with the vertebra, it comes around to the front, it will have cartilage, and then it attaches to the, so a cartilaginous joint, and then it attaches to the sternum. So vertebrosternal means it's going from vertebra to sternum and has a direct joint contact with both of those bones, vertebra and sternum, okay? So that's the first 7. And even though rib number 7 here looks like it's a really elongated piece of cartilage, it is still attaching directly to the sternum. But if you look at the false ribs, which are ribs 8 through 12, okay, and we can break those into 2 different categories. You can have vertebrochondral. What does chondral imply to you? Cartilage, right? Chondros, cartilage. So what you have is number 8 is coming here. Here's where the cartilage starts. It comes up and attaches by cartilage to the cartilage of rib 7. So that's why ribs 8 through 10, if you notice as they come up, are attaching by cartilage to the rib cartilage above. But it's not going to another bone, it's going to the cartilage. That's why they're vertebrochondral. So that'll help you guys remember. Look at the name and it'll remind you. If you look at vertebral ribs, it's not attaching to anything other than the vertebra and the back. So those are your true floating ribs, number 11 and number 12. So number 11 is showing, I'll show it on this side, is coming around and doesn't attach to anything in the front. And number 12 is coming and doesn't attach to anything in the front. So it's only touching the vertebra, thus the name vertebral. Okay, so false ribs are 8 through 12, but 8 through 10 are subcategorized as vertebrochondral. And then vertebral is just subcategorized because it's just touching the vertebra on the posterior dorsal side of the body. Let's see, what else do I want to tell you? Okay. Moving on to the appendicular skeleton. Okay. So these are appendages and how they attach to the skeleton. So we have what's called the pectoral girdle. All right. So it says shoulder girdle is another AKA for that. So you may hear that as that. And it holds the upper extremity to the axial skeleton. There are two actual girdles that attach to the axial skeleton. For the upper extremity via the pectoral girdle. And in a minute, we're going to talk about the lower extremity and how that attaches via the pelvic girdle. Okay, so when you're talking about this, you're talking usually a combo of bones again, right? So we go back to pectoral girdle first, also called shoulder girdle. This is the only attachment, okay, is the clavicle and scapula. That's it. Have you guys noticed how much range of motion you have with your upper extremity, right? You can do like a windmill with your arm, lots of range of motion, okay? Can you do that with your leg? Some people might, like if they're in Cirque du Soleil, I don't know. But most people cannot do like the whole big windmill thing with their leg. Okay, it is, we're going to see the difference between these two ball and socket type joints. And more range of motion also means you can be more likely to injure yourself, right? So you're going to, the reason I'm bringing up the pectoral girdle and shoulder girdle also, and why I want you guys to learn about the rotator cuff muscles in lab, is because at some point in your life, you will yourself or know somebody who will have hurt something with their rotator cuff, especially if they're involved in any sports, if you're in nursing and you're lifting any patients, if you have a fall on an outstretched arm, you're going to hurt something up there. All right, so looking at the clavicle and the scapula, let's see. So this allows for lots of mobility, and the clavicle is also called the collarbone. It has a sternal end and an acromial end. On the sternal end, it's the only attachment point to the axial skeleton. That is crazy, right? Go ahead and feel near that sternal notch that we talked about, sternal angle, I mean, right? And move your arm around, and can you feel some movement under your finger that's touching the sternum and the rib area, clavicle area? You can feel it moving, right? That's the only attachment to the axial skeleton. There. That's it. Is that crazy or what? I don't know. I think that's crazy. Okay. So the upper extremity only has one joint to the axial skeleton. On the acromial end, it's on the lateral side. It articulates with the acromion of the scapula. So scapula, shoulder blade, right? So that, can you see how easy it is to injure when you have an outstretched arm and you fall back or forward and try to reach and stop yourself, right? So if we look at the scapula, that is the shoulder blade. It has a shallow cavity called the glenoid cavity, right? And so if you guys look at your little shallow, this is the socket part for that ball and socket. This doesn't look anything like where the femur comes into the acetabulum, right? From Bone Lab, okay? So the glenoid cavity is for the head of the humerus. So the head of the humerus, you can't see black. Let's try and draw in neon yellow. Nope, can't see that over black either. Never mind, so we'll just keep it with this. So that's where the humerus comes in on the glenoid cavity. All right, and so it articulates with the, whenever I say that. Okay, so when we say the word articulation, do you guys realize that's talking about a joint, right? Okay, so where two bones are coming together. So for the head of the humerus, articulation or shoulder joint. The acromion is on the lateral end of the scapula spine, and the process that articulates with the clavicle, okay, and we call that the AC joint or acromioclavicular joint, okay? So you may hear people say AC joint or acromioclavicular. Now, I wrote that in the wrong spot. AC joint goes there, not where I wrote it. There we go. So there are three reasons why the upper extremity has such great or large mobility. Okay, so one, it's the only one small articulation point, which we just talked about, the sternoclavicular joint, right? And the scapula freely moves over the posterior thorax. So if you guys saw the skeletons in lab, they oftentimes were screwed in with a screw or bolt or whatever to the skeleton so that the arms were in a better position for you guys to study the skeleton. But if you put your hand on the back of your scapula and you move it around, okay, it just glides over the muscles of the back, okay? The deeper muscles over the thorax, over the ribs and those muscles, not the trapezius and stuff. That's overlaying your scapula. But it's just gliding. So hopefully you guys, when you were in Bone Lab, took a scapula and put it over yourself when you were trying to orient what position or what side was anterior and posterior. Of the three fossas on the scapula, which was the supraspinous fossa, infraspinous fossa, or the subscapular fossa, which one is anterior? Subscapular fossa. Because if you put it on your back, supra and infraspinous fossas were on the posterior or dorsal side of your body. The subscapular fossa, even though this is on the back of your body, is facing anteriorly. And if you think about it, if you'd have flipped it over and you had the spine of the scapula on the anterior side, it would bang into your muscles. It wouldn't fit. But when you hold the scapula with the subscapular fossa, the slight curve of that fossa fits nicely over the upper part of your thorax. So next time you guys are in lab, look at those skeletons and you'll see how it sits. And hopefully you guys are making that connection in Bone Lab. But if not, now you are, so that's good. And then the nice thing about all those fossas that we just named on the scapula, guess what the muscles are named that are on it? Supraspinatus muscle is in the supraspinous fossa. Infraspinatus muscle is in the infraspinous fossa. Subscapularis muscle is on the subscapular fossa. Super easy. And then you just have a couple other rotator cuff muscles to add on to that. Easy peasy, right? So look at the names, refer back to the bones. It will help you learn those muscles. And it'll make sense where you're finding them then. Also, the third reason why upper extremity has such great mobility is that the socket is shallow and poorly reinforced. So the rotator cuff muscles, when we learn about those later on, are the only things holding that in place. So when you tear it, you can see why it's so painful for people, right? And how easy it is to move it. So that socket does not really restrict range of motion. So that's why it can move so readily, because it has a shallow socket. So it's like, this is your ball and socket for there. And for the hip, it's like this, right? So we'll see that in a minute. Moving on to the, on the pelvis, do you guys realize why it's such a deep socket on the pelvic girdle? Why do you think it needs to be such a deep ball and socket down there versus the shoulder?
Supporting more weight.
Yeah. All is lower extremity. This is all for weight bearing. Okay, so to distribute the forces of your body weight, of gravity on your spine, allowing you to ambulate, move around, things like that, that's why this is not going to have as much mobility, and it has to be so much more, I'm trying to throw my pen around, so much more forceful to allow to support your body. Okay, so excellent. So, and upper extremity, it's not weight bearing, right? What does it have to lift up and hang on to? Just things that you want to grab and touch and move around. It doesn't have to weight bear anything for your body. Thus, it can also be more freely movable, and why it doesn't have to have such a strong ball and socket area or large. So, talking about the upper limb of the axial skeleton, which comes into your shoulder girdle, we have some of the bones we want to talk about. So, with the humerus, it's the one bone that's in your arm, because remember, the upper part is your arm. The lower part is called your antebrachium, right? So you have brachium is the arm, antebrachium is the forearm. Okay, so this is one bone in the arm, largest and strongest bone of the upper limb. Okay, not the rest of the body, not the whole body. It's just the strongest and largest bone of the upper limb. The other name for this area of the body is the brachium. Head is proximal, so it fits into the glenoid cavity, which we just talked about. The greater and lesser tubercles are both anteriorly located on the bone. So when you were trying to orient whether you were on the anterior or posterior side of the bone in Bone Lab, those tubercles were on the anterior side. So the greater tubercle is the lateral attachment site for rotator cuff muscles, and the lesser tubercle was a medial attachment site for rotator cuff muscles. So remember, tubercles are attachment sites for muscles. Okay. Then we have something called the intertubercular sulcus. So it is between the greater and lesser tubercles, intertubercular, right? That is the anatomical term. The layman's term, or what you will hear out in practice or in various clinics, is going to be the bicipital groove, because it's the long head of the biceps tendon that fits in that groove. So they usually will call it that. Bicipital groove, which is probably a lot easier to say and get out, versus intertubercular sulcus of the bone, right? So let's see, what else do I want to tell you? The deltoid tuberosity. What do you think attaches to that tuberosity? How about the deltoid muscle, right? So that was that thing that was sticking out. Did you guys notice on some of the skeletons it was a lot more pronounced than others? Why was it more obvious on some skeletons than others? Somebody could have been a bodybuilder. Maybe they did a lot more manual labor. They lifted heavier things. Men will tend to have larger tubercles, but it doesn't mean that a female won't have a large deltoid tuberosity, right? If they're weightlifting, if they're lifting heavy things. If it's the muscle tugging on the bone, the tuberosity or tubercle will be a little larger. Okay? So remember, these are attachment sites. So it's the lateral attachment point for the deltoid muscle. On the distal end, you have two condyles. Okay? And if you put yourself in anatomical position, remember, so palms facing outward, thumb is out laterally. That's how you have to look at when you're trying to say whether something's medial or lateral when you're talking about bones. So if I'm asking you a question on the exam, I'm always talking about anatomical position. Okay? So on the medial side, you're going to have the trochlea, which articulates with the ulnar bone, which is on the pinky side. So again, as long as you're in anatomical position, you're saying the same thing. And then the capitulum is on the lateral side and articulates with the radius. Okay? Epicondyles, epi, upon or above. So these are little mini condyles upon or above the condyles, right? So also points of muscle attachment, and I wrote in there above condyles. So, and we also have a lateral epicondyle and we had a medial epicondyle, right? If we look at the antebrachium, this is the forearm. There are two bones in the antebrachium. We have the radius and the ulna. If we look at the ulna first, this is longer actually than the radius, and it forms most of what you guys consider is your elbow. So if you put your elbow on the table, what you're talking about is that is the ulna, that is the pointy part sticking out there, right? Okay. So that's the olecranon process that you're feeling when you guys looked at the ulna, and it's a posterior process. It locks to prevent hyperextension. So I am not, like the term people say double jointed. It would mean that they would have increased range of motion in the extension direction. So mine is flat. Somebody else might stick out their arm and it bends like down a little bit. Mine doesn't. So anybody stick theirs up? Yeah. So, and double jointed doesn't mean you have two joints. It just means you either have lax ligaments, they allow for more range of motion, or the way that the bone might be shaped a little bit that allows for a slightly increased range of motion. So this locks to prevent hyperextension with the olecranon fossa that you found on the humerus, right? Did you notice how they locked in place nice and easy when you played with the bones and put them together? The head is actually distal, okay? Which is kind of weird. We always think of the head as being closer into the body, but remember, on the ulna, the head is distal. It contains a styloid process, so a little pointy thing sticking off there. It plays no role in hand movement. So the ulna doesn't do anything with moving your hand. All it does is supinate and pronate the antebrachium, which your hand is following that motion, right? But it's not technically moving the hand. You're really talking about here. And what happens when you supinate and pronate your antebrachium or forearm? You're crossing the radius and the ulna, right? Correct? I should say not right or left. Okay, so when that happens, you also have something I'm going to talk about in a second called an interosseous membrane, which is between the two bones. Okay, so I'll come back to that in just a second. Supination, an easy way to remember supinating is rotating the forearm, that's your hand. It looks like a soup spoon, so in order to eat soup, you got to have it cupped up. You can't eat soup upside down, right? So supination is this range of motion of palm coming upward, and pronation would be the palm going down or outward, okay? So flipping the hand up like you could do soup is supination. Pronation is flipping down. So you would spill your can of soda if you do pronation, okay? So the proximal articulation would be with the trochlea of the humerus, which we said was on the medial side, so this makes sense, right? The radius, that is the lateral, when again, we're always talking about anatomical position. The head is proximal, which is what you usually think of. So maybe you just have to memorize ulna's head is distal, and everybody else you can think is proximal, right? So the head is proximal. It articulates with the capitulum, which makes sense because we said on the humerus that was a lateral landmark, right? And then talking about the interosseous membrane, this is a flat, flexible ligament for the most part, okay? So what happens is it's made out of dense, regular CT. It's between the radius and the ulna. And do you guys remember seeing that little bit of a ridge on the lateral aspect of the ulna, medial aspect of the radius? That ridge is where that interosseous membrane is attaching between the two bones. And that's why that ridge ran along most of the aspect of both bones, okay? So the point of that interosseous membrane is it stabilizes things when you supinate and pronate. So it's preventing things from sliding together or too far apart when you do that range of motion, and preventing other things from shifting and moving. But it's also flexible, so it allows more range of motion there versus when we talk about between the tibia and the fibula of the leg, okay? What else do I want to tell you? So the interosseous membrane is a ligament. The one between tibia and fibula is not flexible, but the one between the radius and ulna is flexible, and it also helps with stability, okay? And let's see, moving on to the hand. So we have the wrist, palm, and fingers that make up the hand. Another name for the wrist is the carpus. So a lot of times we'll call those carpal bones, right, when you guys were learning those. So those are 8 bones in 2 rows, so 4 bones are in each of those 2 rows. And if we talk about the metacarpus, you're talking about the long bones that are coming into contact with the carpal bones at the wrist. And so those are numbered 1 through 5. If you're in anatomical position, number 1 starts with the thumb in this sense. So thumb is number 1. Number 5 would be your pinky. So number 1 is medial or lateral? Metacarpal 1 is, it's a lateral bone in anatomical position, right? Because your thumbs are lateral in anatomical position. Let's see, so the head of the metacarpus would be on the distal portion away from the body. So another one to memorize, that the head is distal. The shaft is, just like any shaft of a long bone. The base is going to be proximal. So the base is what's articulating with your carpus bones. If you make a clenched fist, okay, so the head of the knuckle, okay, is part of the metacarpus, okay? Let's see, phalanges. Those are the long bones of your fingers. For digits, number 1 through number 5, each digit has 3 phalanges, a proximal, middle, and distal, except for the thumb. The thumb only has a proximal and a distal phalange, okay? And what else do I want to tell you? Let's see, that's the upper extremity. Now we get to do the middle extremity. Middle? No, lower, right? I was looking at the middle as the one that's missing on the thumb. All right, so talking about the lower extremity, first talking about the pelvic girdle, aka the hip bone, aka the os coxa bone. So hopefully you guys realized in lab that the hip bone is not your femur with the greater trochanter. But I will tell you that lay people, that's what they think is the hip bone. Okay, so when they say my hip hurts, you got to have them point to where it hurts, because they may be talking about their hip down here. but this is your hip up here. When people put their hands on their hips and they give you that stern look like, right? They're putting their hands on their hips. This is your hip bone. That's the top of your ilium of the os coxa bone, okay? That's your hip bone, the os coxa. So keep that in mind. Be specific, anatomical when you're on the exam. Don't fall into the trap of the layperson anymore. Now you guys know the correct terminology, okay? So pelvic girdle, hip bone, os coxa bone. It's a complex bone like the sphenoid bone was, and it's the most complex one to have to learn all the parts as far as for the lower extremity. And this is the attachment of the lower extremity to the axial skeleton. So let's see, what else do I want to say? When you guys were in lab, you guys had to learn all of the lots of every little indentation, pokey part, ridge, everything, okay? For lecture exam, focus on what's in the notes. Hopefully you already know most of the other stuff if it gives you an idea of where you're trying to think of anatomically where something is in relationship to something else. But don't focus on relearning all of that. Hopefully you got that under your belt, but focus on what's in the text of my notes. So all of these landmarks should be in your lab composition book. For exam 3, focus on the text. Some things that are important to note on here, though, lecture-wise, is when you sit down, the bony part, especially when you sit in a hard chair, that bony part that you're sitting on, some people will call them your sits bones, that is from the ramus, that's right here, from the ramus of the ischium of your os coxa bone. That's what you're sitting on when you feel that bony part, or when you're in a hard chair and you're like, wow, this is not very cushioned, right? That's what you're feeling there. Another thing to note would be where the pubic symphysis would be, which is between the two os coxa bones anteriorly, between the pubic tubercles, okay? And another one would be, it's always a good idea to know the acetabulum. You know on the acetabulum that is telling you it's on the lateral aspect of the bone, right? Because the acetabulum is also important because that's where the 3 bones that make up the os coxa bone, when they fuse together, all 3 of them are part of the acetabulum. So if you were to separate this kind of like this, so this is your ischial bone, this is your ilium, and this one would be the pubic bone. So one of the I's, the other I, and the other P are making up the acetabulum. Okay. The pelvic girdle is just a bone. It is the os coxa bone, right? So keep that in mind, because when you talk about the term pelvis, you're talking about a combination of bones, and it's a structure, not a single bone, okay? So a pelvis is the structure. It is made up of 2 os coxa bones, the sacrum and the coccyx, okay? Now you guys hopefully realize, because I said that this connects, the os coxa bone connects the appendicular skeleton of the lower extremity to the axial skeleton. So os coxa bones are appendicular or axial? Appendicular, and sacrum and coccyx are axial, okay? So what would be the connection between the os coxa and the sacrum? What is its articulation called? I just told it to you at the beginning of this lecture, and you've already forgotten. The sacroiliac joint, thank you. Yes, the SI joint, that's your connection. That's the articulation between the lower extremity appendicular to the axial skeleton, okay? So, wanted to point that one out to you. What else do I want to say? So, about the pelvis. So, each os coxa bone is divided into 3 bones, which we just talked about, ilium, ischium, and pubis. The ilium is the largest flaring portion superiorly, which we pointed out. The ischium is the posterior inferior part of the os coxa bone. It has a thick part that joins to the ilium, the thinner ramus, which joins to the pubic bone anteriorly. It has the ischial tuberosities, which are the inferior most part, which is your sits bone part that you're sitting on, right? And then the pubis is the anterior-most portion of the coccyx. Most of you guys realize that part. And it has a fibrocartilage disc, which forms the midline of the symphysis pubis. So what did we say was important about fibrocartilage? We have it in the intervertebral discs as well as here. Shock absorption, right? So this is a weight-bearing, anything we're talking about from here on down with lower extremity has to do with weight-bearing. So you are distributing the weight of the upper part of the body and gravity. You're distributing weight as you walk and move and ambulate. So there is some movement going on at the pubic symphysis, especially noticeable when women are pregnant and later in the pregnancy, or their ligaments get more lax because they're getting ready to deliver at some point. And so even more shock absorption is needed there, right? So that's the fibrocartilage disc between the pubic bones. On the lower extremity, it's broken up into thigh, leg, and foot. So the femur is your thigh bone, not the hip bone, right? So femur is thigh. It's the largest, strongest bone in the body. So this one is largest, strongest bone of the whole body, okay? It has a head, which is on proximal side, articulates with the acetabulum of the os coxa bone. The neck is typically where it's considered the weakest point. So when somebody says that they've broken their hip or they've fractured, FX means fracture. And just so you know, when you're in practice and you ask somebody if they've ever had a fracture, and they'll say, no, And you're like, are you sure? And they're like, no, I had a crack. It's a fracture. If the epiphysis shifts and moves, that's a fracture. If it, on little kids, they can have what's called a green stick fracture. It didn't snap, it just bent and went, well, it's a fracture. So the lay people don't understand that when you say fracture, that you don't just mean a crack. They think a fracture means it had to totally snap in half, and it doesn't mean like a little hairline crack in it. It's the same thing. Those are all fractures. So just putting that out there. So the angle of the attachment to the shaft is what centers your knee. You actually have something called a Q angle. You guys don't have to know that. But they can measure that to see when somebody's walking and they end up putting too much pressure on their knee or into the foot. Their angle might be off up here, depending on things being not in quite the right position and stuff. On the proximal side, you have a greater and lesser trochanter, which are for muscle attachment points, okay? And laterally or lateral and medial condyles on the distal end will be for articulating with the tibia. And that's the only place that articulates with the tibia. So the fibula is not articulating with the femur, okay? The patellar surface anteriorly is covered with articular cartilage for the patella. So the patellar surface of the femur is telling you on that anterior surface you're going to have articular cartilage. So when you talk about the patella, it also will have articular cartilage so that they are moving over each other and creating that knee joint space, okay? The leg is between the knee and the ankle, okay? So you have two bones that make up the leg portion, the tibia and the fibula. There is no movement between the two, unlike the radius and the ulna. So you also have an interosseous membrane, okay? But it's more, it doesn't have the flexibility that you had for the supination and pronation of the radius and ulna, okay? So this is more like it's buddy taped to the tibia. If you had to buddy tape two fingers, what are you trying to do? You're immobilizing it, you're splinting it. You're not letting them move a whole lot. That's what the interosseous membrane is between the tibia and the fibula. It's not for flexibility. This is just for stability, okay? And let's see, what else do I want to tell you? Yep. All right, if we're talking about the tibia, a lot of people, another AKA for tibia would be the shin bone. So this is the medial bone of the leg. It supports the entire weight from the femur, transferring the weight to the ankle, because again, the tibia does not articulate with the femur, okay? So the shaft is the anterior surface that most of you guys associate with calling the shin, okay? So if you've ever had shin splints, when we talked about Sharpie's fibers being pulled off from the periosteum to the bone. Okay, when you're tearing that and it's quite painful, that is not fun. That's where you're talking about that area. You have the medial and lateral condyles, so they are proximal articulation with the femur. So that's saying up, right, proximal. The tibial tuberosity, most of you guys know what that is. That's the little bony protuberance that you guys feel just below the knee on the anterior portion of the tibia. That's your tibial tuberosity. The patellar ligament is attaching there. So some people can have problems where if they are tugging on that a lot, their tibial tuberosity will be a lot more pronounced because, again, you're tugging on the bone. Tuberosities grow in response to stress. So if somebody doesn't have a lot of stress on there, they may not have a really bony protuberance there, right? The medial malleolus, I say malleolus, all right, forms the medial bulge of the ankle. So when you feel what people call their ankle and you feel that bony part sticking out, that's the medial malleolus. That's from the tibia. That's what you're feeling. That's that part. So hopefully you guys look at that again when you see the skeletons in lab, okay? The fibula does not bear any weight. It's the lateral bone of the leg, so the outside part. We already talked about the interosseous membrane, and it makes up the lateral malleolus, okay? So that's the lateral bulge of the ankle. So what you feel, that bumpy part on the outside, that's your fibula. Also, just so you guys know, you don't need to know it for this, but that's the most common area to have fractured when you sprain your ankle. It's that distal portion of the fibula, okay? Let's see. Talking about what else do I want to tell you? So on the tibial tuberosity, just to go back up here for a second, so that was the attachment site for the patellar ligament anteriorly. So ligaments and tendons are both made of dense, regular CT, okay? So ligament, do you guys realize, is an attachment from bone to bone. So it goes bone, ligament, bone. But a tendon is going from muscle, tendon to bone. Okay, that's the difference between a tendon and a ligament. So you have a patellar ligament, which is from the patella bone to the tibia, because you're going bone, ligament, bone, patellar ligament. But you have a quadriceps tendon, because you're going from the quadricep muscle to a tendon to the patellar bone, right? So that might help you guys realize why it was called slightly different things. If we look at the foot, we have an ankle, which we're going to call the tarsals. We have the instep, which are going to be made up of the metatarsals. And then the toes, guess what? They're also called phalanges. That makes that part easy. On the tarsals, we have 7 ankle bones. In the wrist, we had 8 carpal bones. Okay? So 8 carpals, but only 7 tarsals. The 2 largest tarsals support the weight of the body. You have the talus and the calcaneus. Okay, so the calcaneus is what makes up your heel when you are banging your heel or you feel down on the heel. Let's see. And what else do I want to tell you? Which of those 2 bones articulates with the tibia? Talus or calcaneus? The talus. Remember, it had a nice smooth edge on top that when you looked at the tibia, you could see it move over the talus of the foot. Okay. And what else do I want to tell you? The Achilles tendon attaches to the calcaneus. And there's another name for the Achilles tendon. It's also called the calcaneal tendon because it's attaching to the calcaneus. So Achilles tendon is more like a layman's term. Calcaneal tendon is the probably more appropriate anatomical term, but both are, you guys know where they are now. Metatarsals, the instep, there are 5 of them, just like the metacarpals. So they're numbered 1 through 5, but starting at the big toe. So luckily the thumb was number 1 for the hand. The big toe is number 1 from the foot. But where is number 1 located? Medial or lateral on the foot? Medial, okay? So when you're reading questions, think about it on your own body and then answer it, right? So that you don't get confused and just shoot for it. Let's see. Phalanges are the toes, same structure as the phalanges in the fingers, but smaller. So you have the proximal, middle, distal, right? Arches of the foot, there are 3 of them, all help with the weight transfer of the body. You guys are probably most familiar with the medial longitudinal arch, which is the highest arch, the arch of your foot, right? So digit one side of the foot unless you are flat-footed. So if you had a footprint in the sand, you don't see it flatten out completely when you step down, right? You'll see like that open spot of your foot. So it's kind of like this. And here's your big toe side, right? So this area doesn't flatten out unless you're flat-footed. You wouldn't see it. If you were flat-footed, it would kind of be more like a rectangle-y shape, right? Okay. So the three arches allow for springiness, which is for shock absorption or strength of the foot. So if we look at the lateral longitudinal, so this elevates the foot just enough to transfer weight to the head of the fifth metatarsal. So this is on the lateral side of the foot. You're talking about over here, okay? And this does flatten out when you see a footprint because you see that side of the foot, correct? And then there's a transverse one. This runs medial to lateral, and this is what creates the bridge or dorsum of your foot, okay? So, we are, I guess I could scroll up a little bit so you can see that. So, transverse runs medial to lateral, bridge or dorsum of the foot. Dorsum is the top of your foot, okay? So that is the end of chapter 8. Now we get to move on to chapter 9, which is the skeletal system articulations. Ding. Okay. So we have been talking about bones. Now we get to talk about joints. So classification of joints, where two bones come together to form an articulation. When we're talking about articulation, we're usually talking about or thinking about mobility of some sort, right? However, some joints are not designed for mobility, so you may or may not have a joint space between two bones sometimes. There are three functional type of joints that we're going to talk about. Arthroses means mobility. So there is a synarthrosis, an amphiarthrosis, or a diarthrosis. So synarthrosis is immovable joints, meaning they don't move. And these are either of fibrous or cartilaginous material between the bone ends, okay? If you have an amphiarthrosis, you can think like sort of, kind of, if you want. So slightly movable, so there's some movement. And this would be cartilaginous material between bones. And then the diarthrosis are the freely mobile or movable type joints. So these are synovial joints, and these are the most common type of joint of the body and what we're going to be talking about typically. If we look at structural, so that's like talking about the anatomical, the anatomy side, when we talked about functional being the physiology side kind of. So now we're talking about structurally. If we're looking at fibrous joints, okay, so there are three sutures, three fibrous joints. We're talking about sutures, syndesmoses, or gumphoses. So of the fibrous joints, these are bones that are joined by fibrous CT. There is no cavity and thus no movement. So remember I said some joints may not have a joint space, right? So synarthrotic would be what these are like because we're saying these are immovable, right? So I want you guys to think back, relate the functional side with the type of joint that we're talking about. Go back and refer back and forth so that you feel comfortable with that. So these are synarthrotic, but there is one exception. There's always one exception, right? So I'll talk about that exception in just a second. If we look at the pictures, so of the three, suture, syndesmoses, and gumphoses. The first picture, when they're talking about the teeth, they're talking about a gumphoses. Okay, so this is CT fibers hold the teeth in the bony sockets. So this is like a peg and socket type of joint. Okay, so, and the attachments they're talking about are right here. This is the CT that's holding it in place. There's not really a joint space. This is made up by the periodontal membrane, but it's holding the root of the tooth into the alveolar process of the mandible, which was a bone, right? And so the gumphoses is that attachment of keeping the bone to the bone in that spot, okay? This is dense regular CT. It's synarthrotic. So your teeth shouldn't be moving at all in the socket, right? Unless you're a little kid and you're supposed to lose that tooth and get a new one in place. Otherwise, you don't get another one, and it's not good if you have loose teeth as an adult, okay? If we look at the next one, sutures in the picture, okay? So sutures are short collagen fibers interlocking skull bones together, okay? So remember when we talked about the diploe of the cranial bones? So what you want to notice here is, do you see how it's like that interlocking? Kind of think of like a puzzle piece, okay? So they fit together, it's interlocking. This is also dense regular CT. Do these move, do you think? Is this a synarthrosis, amphiarthrosis, or diarthrosis? No. Synarthrosis. Yes. Yes. For exam purposes, for learning in A&P, it is a synarthrosis. Yes, in chiropractic and in massage, they will talk about how cranial bones can shift and move a little bit. And you guys kind of know this too. If you have a headache, have you ever squeezed your head together really tight? And then it kind of let off some of the pressure and you felt a little better? So there is some slight movement, but don't call it, for our purposes, an amphiarthrosis. This is a synarthrosis for our purposes, okay? But Alan is correct. Yes, but for exam purposes, synarthrosis.
The purpose was the cerebral spinal fluid to help.
Yes, it does. You don't need to know that for in here, but yes. Also, if you think about it too, it wasn't originally a synarthrosis when you're a fetus, right? Your cranial bones have to shift and actually overlap a little bit when you are being born through the birth canal. And that's an important thing, not that you guys need to learn about that right now. And then after you are delivered through the vaginal canal, not a C-section, but the vaginal canal, then, you know, your baby looks kind of like an alien. Do you ever notice that? With like weird lines and pointy parts sometimes. And then after about a day or so, things kind of relax into shape. And then the cranial bones look a little more normal. You have a more normal looking baby. Why do you think they stick the little hats on the baby's heads? So you don't think it's an alien. All right, so, but for our purposes, for sutures, cranial bones, synarthrosis, okay? And then the last one that we're talking about over here is talking about a syndesmosis, okay? So bones connected by a sheet of fibrous CT or ligaments. And that's exactly what we're talking about on the interosseous membrane or ligament, which is between the radius and ulna. Okay, so this does allow for that supination, pronation range of motion, right? So we actually have some mobility there, anywhere from a synarthrotic to a diarthrotic functional joint. Okay, so between the radius and ulna, dense regular CT, and it allows for the supination and pronation. But between the tibia and fibula, I told you it doesn't move, right? So that would be more of a synarthrotic joint, correct? But this is showing you the radius and the ulna here. So that's why we were talking about, and again, a syndesmosis could range from how much movement is allowed in that joint. And just kind of think of those two examples. Let's see, where are we at? So cartilaginous joints. So now we're moving on to another type of joint. So we have two to learn, synchondrosis and symphysis, okay? The difference is whether the amount of range of motion it allows and the type of cartilage. The two types of cartilage we're going to talk about are hyaline or fibrocartilage, right? We don't talk about elastic cartilage because where do we only find that? E for external ear. Is there a joint with that cartilage? No. And epiglottis, also not a joint. So you can rule out elastic cartilage and just think hyaline or fibrocartilage there. So with a synchondrosis, so when I was saying, sorry, real quick, the one exception to fibrous joints having no movement, the syndesmosis was your exception. Because depending on whether you're talking the interosseous membrane of the radius and ulna, there is movement. That was your exception there, okay? I just forgot to point that out there. Let's see, also the gumphosis, I told you that was dense regular CT, right? Okay. Okay, back to cartilaginous joints. If we have synchondrosis, chondro tells you what? cartilage, right? So chondro, we're talking about cartilage. So it's a plate of hyaline cartilage in between bones. So one example is the epiphyseal plate in long bones of a child, because a plate is in the child, epiphyseal line is in the adult, right? So we have epiphyseal plate, okay? And if you had, I briefly mentioned it, you know, an epiphyseal fracture, okay, that could affect how well a child might grow, because this child is still growing. You have now affected an area that is in process of growing, and if you get a fracture there, so a slippage is typically what it is, although you could have a crack there as well, you potentially, especially on the weight-bearing part, could stunt the height of somebody or cause a short leg versus a long leg on somebody, okay? The other is an actual attachment of the first rib to the sternum. Not the other ribs, just the first rib to the sternum. Okay, it has a long bar of cartilage, and so they're talking about just the joint of the first rib to the sternum, and this does not move or shift around. Okay, so that's a synchondrosis. It's not moving. So no range of motion, no movement with those two. Okay, ROM is range of motion, or you can put movement in there in your notes. If we talk about a symphysis, this is a pad of fibrocartilage which is found between bones. It's an amphiarthrosis because there is some motion there. So where do we have symphysis? Symphysis pubis, okay? So that is fibrocartilage. We said also intervertebral discs, right? So intervertebral disc allows for some movement, right? Because you can move your spine, flex, extend, lateral flex, that kind of thing. Okay, and especially the symphysis pubis movement-wise when we're talking about delivery of a baby. Third kind of joint that we want to talk about are the synovial joints. So these are all freely movable. Ends of the bones are covered by articular cartilage. Okay, so freely movable means it's what kind of joint out of those three we talked about first? Syn, amphi, di. These are diarthrotic joints because they're freely movable, diarthroses, okay? Let's see. The space between bones we call a joint cavity. We have synovial fluid in that joint cavity. Who do you think makes synovial fluid? The synovial membrane will do that. So the joint or articular capsule, you have fibrous component and a synovial component. The fibrous component is kind of like the periosteum, and the synovial component on the periosteum would be like the living cells of it, of the areolar CT, that type of thing. That's what's going to produce the synovial fluid then. Let's see, what else do I want to tell you? General structure. So there are several basic features of all synovial joints. All right, so we have articular cartilage found at the surface where the bones meet. We have a joint cavity, which is filled with synovial fluid. We have the articular capsule, which is a double layered structure enclosing cavity. And then you have the fibrous capsule. So what they're talking about on the articular capsule, so they're talking about the fibrous and synovial membrane. So you have this part, and then you have the purpley part also there. Okay, that's what they mean by the two parts there. So the fibrous capsule is the outer layer connected to the periostea of both bones, so that's why it extends to here to the periosteum. We kind of drew that with our long bone for exam 2. Do you guys remember a little bit of that? And then the synovial membrane is the areolar CT, okay, which is lining the fibrous capsule. Let me erase that extra line I put there by accident, that guy. Sorry. Okay. And so this is, keeps the bones from touching, and it's also a lubricant. It's simple squamous epithelium on top of the synovial membrane, makes the synovial fluid. So I want to put on here with synovial fluid that it is produced by synovial membrane, which minimizes friction and nourishes the articular cartilage. Okay. It has a rich nerve and blood vessel supply because with injuries, you could get pooling into the blood space, right? Ever seen an ACL tear? Huge amount of blood fills up in that joint cavity. Reinforcing ligaments, so you have capsular, extracapsular, and intracapsular ligaments. If we talk about the extrinsic or extracapsular, so this can separate from the joint capsule, and these ligaments are from the joint capsule, so can separate from JT for joint capsule. And then intrinsic is intracapsular, so think within, right? So it's part of the joint space. All right, and so you can think like the ACL or PCL, anterior cruciate ligament, posterior cruciate ligament. So you guys should have looked at the joint models when you guys were in lab before. And let's see, real quickly, bursa is a flat fibrous sacs filled with synovial fluid. So if it has synovial fluid, what produced the synovial fluid here? Still synovial membrane, right? So the bursa are found where MM is muscle, ligaments, or skin rub over the surface of the bone. Yep, can even be tendons. And again, it's for reducing friction. Okay, so for example, a bursa is kind of like the articular capsule minus everything else. So it has a fibrous capsule, a synovial membrane, and it has synovial fluid in it, right? It's protective. You don't really are aware of bursas unless it gets irritated, inflamed, or an infection. So bursitis means inflammation of the bursa, and it could be from overuse. It could be from some other kind of trauma. Overuse is a type of trauma, by the way. And there's like one thing called Popeye's elbow. I actually had a patient that had that, where his olecranon bursa was so inflamed. The only thing I can think of, I don't think he banged into anything, but he had Alzheimer's, so you can't be for sure. He may not remember what he had banged into. But he sat in a wheelchair most of the time and would lean on his elbows constantly. So it was probably overuse of leaning on the elbow on the wheelchair arm. He tended to lean to that side. And this thing was sticking out huge. And that's why they call it Popeye's elbow, because if you think about Popeye the Sailor Man, right, the spinach guy, how huge his funky knobby elbows were. It literally was huge. It wasn't tender when you pressed on it, so it didn't hurt him, but it was very obvious and it shouldn't have been there. And so I told him his other doctor might have to take fluid off of it, or may give him, depending on what his medications are and if he was able to be on it, potential anti-inflammatory to get it to calm down. And it finally did calm down, but that was the biggest bursitis case I'd ever seen. I'd had other patients that had bursitis, but it wasn't sticking out like that Popeye's elbow. Let's see, where else might people feel it? So you might feel it above your knee, under the muscle there. Patella bursa, so there's a couple here. There's infrapatellar bursas. There's a prepatellar bursa there. There's bursa deep to the gastrocnemius muscle. So sometimes people will hurt themselves and they can't fully extend their leg. Oh shoot, what's it called? Oh, nuts. I'll remember the name of it. Darn it. Now I can't think. Anyway, you could have a bursa there. And if it gets filled up with fluid, could you see that it might restrict range of motion and not allow you to fully extend your leg because something's back there taking up space and it's poofy and things like that. And a lot of times they just have to rest, but sometimes if it's so enlarged and inflamed, you have to do something for them. So we will finish up bursa and tendon sheaths next time, and then move on to the, what else are we moving on to? Then we're going to move on to the actual ranges of motion, classification of the synovial joints, finishing this chapter, and we'll move on to muscles on Thursday's lecture. All right.